Hello friends, I am presenting a case of broad ligament fibroid for which myomectomy was done. Here we can see there is a enlargement of the left broad ligament. Round ligament is pushed more anteriorly. Even the fallopian tube can be seen stretched over the fibroid. These are all the evidence of a broad ligament fibroid. And since it is on left side, so we call it as a left broad ligament fibroid. Vasopressin injection was injected onto the uterus, which is in 10% dilution, nearly 200 ml of normal saline diluted in 20 units of vasopressin injected to the uterus. We will get a bloodless field during surgery. Using harmonic scalpel, we will have an added advantage over less smoke when compared to using incision with the unipolar. The surgery should be started with the incision on the most prominent part of the myoma and extend the incision till we get the myoma, which can be seen by smooth shiny surface. The adjacent myometrium will be rough pink in color when compared to a myoma, which will be smooth and shiny. The incision should be big enough to deliver the myoma. We should not try to take out the myoma through a narrow incision. Even the dissection should be fiber by fiber dissection. And if any vessels are seen on the surface, should be coagulated so that there will not be significant amount of blood loss. The significant amount of incision we are extending, and try to find the plane between the myoma and adjacent normal myometrium. Then the dissection becomes easier. Harmonic scalpel in the fast mode, that is maximum mode, is used to take incision. So we can see the myometrial fibers stretching over the leiomyoma, which can be easily identified, and then they are divided. Here we are using a sharp dissection till we find a plane between the myoma and. So once we get the plane between the myoma and the adjacent myometrium, the dissection goes very faster. Till then we should be patient enough to find a proper plane. We can see now we are able to find the proper plane between the. So these are all the myocytes that are stretching over the myoma. They have a very good strength. Unless we cut them, they will not give the way for the myoma to come out. We can see once we cut the myometrium, they stretch out apart and they give the way for a enucleation of myoma. So dissection should be kept very slow, steady. You should not try to tear it out when the field becomes more bloody, and we can lose the plane between the. So whenever we take an incision, care should be taken that we do not injure important structures like fallopian tube. In the broad ligament, we should be aware that we are working very close to the lateral pelvis where major vessels are present, and even the ureter also may be present. Broad ligament will have a rich blood supply which may be stretching over this. So when we can see that these are the some of the small fibers still holding each other and keeping the myoma inside. So once we cut these fibers, then it becomes easy to enucleate the leiomyoma. So the most important step about the incision is take a incision on the prominent part away from a fallopian tube, and find the proper plane between the myoma and adjacent. So now we are able to find a plane. We can see some of the blood vessels are running on the surface of the leiomyoma. They better coagulated, or they can be cut with the slow mode of the harmonic scalpel, which will seal the vessels completely. So we can see good amount of myometrium has been cut before we reach the leiomyoma. Nearly 1 centimeter of deep incision before we could reach the leiomyoma. So now we can able to. So now enucleation becomes much more easier as we get the proper plane between the leiomyoma and the fibroid. Leiomyoma and the myometrium, adjacent myometrium, which is a pseudo capsule formed by the adjacent myometrium. So now we can use myoma screw to take the myoma out of the bed. So this is the region where incision should be big enough to take the myoma out. If we are trying to take it to a normal small incision, then definitely you will be struggling, or we may extend the incision laterally, which is more dangerous than dissecting a proper myoma in a wide incision. While we pull the leiomyoma out of the bed, we can see much clearly the normal plane, and the myometrium can be seen very easily. So even if it is coming out easily, we should not tear it out. Instead, separate all the myometrium, and if any myometrium seen stuck on the leiomyoma, they are divided. So we can see some of the blood vessels are running on the surface, which are feeding vessels to the leiomyoma. They need to be sealed, and then they are separated. So even though vasopressin injection is given to the uterus, still we can see some amount of bleeding. So that is the reason we should coagulate it completely. So this is the proper identification of the plane between the leiomyoma and the adjacent myometrium which forms as a pseudo capsule on the surface of the fibroid. So even harmonic scalpel gives a very good clear view all throughout the dissection. If you are using a unipolar energetics for taking incision, that will produce more amount of smoke, and with the blood present during the surgery, it produces even more smoke that can hamper the vision. We can see a last bit of fibers are attached to the leiomyoma which are being divided. So whenever you are using a myoma screw, make sure that it is properly pricked into the myoma and we do not overshoot or we do not slip away, because once the myoma screw slips off the leiomyoma, so there is a possibility of it hitting the adjacent important structures like abdominal wall, intestine or pelvic vessels. So using a myoma drive is also should be very careful because it is a very sharp instrument and it should not be slipping away while doing the surgery. So this is the last bit of attachment of the myometrium to the fibroid is being released. This is almost an unedited video of demonstrating a enucleation of the leiomyoma. So now we can see the site of the dead space that is present. So it is in the definitely it is in the left side, in the left broad ligament. A part of a right part of the left part of the myometrium is present. Otherwise, major part of the leiomyoma was there in the broad ligament. Some part was there in the intramural part. So we are using a barbed sutures for suturing the myoma bed. So this is the way to hold the needle. First you have to hold the needle with the left hand or toothed needle driver. Then hold it near the hub of the needle and then try to manipulate with the suture. And then how exactly you want to hold it. You can hold it with the dominant hand, either right hand or left hand. And we are using a ipsilateral port for suturing technique. So the deepest part of the dead space should be taken first, and care should be taken that we do not injure any vessels. As I mentioned, the myoma is a broad ligament myoma, and while taking that we do not include a ureter. So we can see that is the ureter running down. So we are well safe away from the ureter. So better to work inside the dead space so that we do not include any important structures like pelvic vessels or the ureter in the incision, in the suturing. Which may increase the morbidity of the patients. So initially 1 or 2 stitches will be taking more time. So once we take initial stitches, then it becomes avascular, and the plane of suturing also becomes more clear. So better to reconstruct the anatomy, how we are remove the myoma out of the bed, so that minimal number of sutures are used and we'll have a completely normal shape of the uterus, which again prevents the hematoma formation. So we are taking the deep stitches as much as possible. We are nearly closing this myoma bed in 3 layers. First initial 2 or 3 deeper stitches, and then middle layer, and then the outer layer are being closed. So this is the plan of suturing for this dead space, which is significant. Nearly 9 cm of leiomyoma has been enucleated. So now we are going to the second layer. Major part of the myometrium is being attached to the adjacent myometrium. So if we are working inside the uterus, the less chances of injuring the important pelvic structures. So if the suturing goes out of the uterus, so it is then the danger comes. So now we can see that after 3 stitches, the vascular bed has become clear. No much of bleeding is there. So now we have to complete the process of approximating the myometrium, where an incision was taken. Still we are running the second layer. So even the suturing also we are showing almost unedited, so that we'll get a proper idea of suturing in a difficult case like this. Barbed sutures are again a very big bone, very big advantage when multiple stitches has to be taken. So they maintain a uniform tension all through the sutures, and you need not keep a stay stitches. So obliteration of dead space is also very excellent. And it is faster way of suturing, especially for myomectomy. So myomectomy needs a very good suturing skill. So as we do more and more myomectomy, we'll get more well versed with the suturing technique. So this is the 45 centimeter of number 1 barbed suture. It's a delayed absorbable suture is being used for the suturing. So now we almost obliteration dead space has been done. So now we can go to the third layer of suturing. That is to approximate the seromuscular layer. So we should remember how the incision was taken and try to reconstruct it. So uterus will be brought back to the almost near normal position. So this is the third layer closure by So we are having a idea where the round ligament is there. We are trying to keep all the sutures anterior to the round ligament so that we do not include the fallopian tube while we approximate the dead space. So now we are getting almost the shape of the uterus back to normal. So now we can see the body of the uterus and other half of the uterus which is completely normal. It was only the left side of the broad ligament fibroid was there, and the left part of the anterior part of the uterus was holding the leiomyoma. So now we are going baseball sutures to cover the seromuscular. So serosa being mainly seromuscular layer is being approximated back into the vaginal position. So yet it has almost nearly 30 minutes since the start of the surgery. So we can see still some part of the uterus is showing a bloodless field and some part is showing the pink in color where the vascularity has been brought back. So once we approximate and do the morcellation, so by that time we will understand that all the effect of vasopressin has been waned off, and if any bleeding is there which can be tackled. So this is the final view when we approximate. So myoma was retrieved by power morcellator. So whenever we are using a power morcellation, make sure that the bevel edge of the morcellator is on the surface and pull it gently. Should not try to over pull it. Keep it slowly so that major chunk of myoma, major strip of myoma can be done as we are done in this case. Nearly 50 centimeter of myoma strip we have got with this, and also it depends upon the type of the myoma, if it is degenerated or if it is having a calcific degeneration, so then it becomes tougher. But in this case it was soft, there was only hyaline degeneration was present, so we could get a very long strip of myoma, means major part of the leiomyoma we could take it out with the first bite of strip. So we are showing even the morcellation skill here. So this is a continuous video without any editing also. So this complete the. So now we close the suturing bed by using a interseed, that is oxidized cellulose, to prevent adhesion formation. So in this case it was very good approximation was there. So there was a clear approximation of serosa. So we can see the uterus has become pink in color, and that means blood supply to the uterus has brought back, and there is no oozing that is coming out from the site of the incision. So that shows that there is a very good hemostasis is present. This is complete about this video. Thank you for watching this video, and if there are any comments, please put in the comment box.